So Chris Booker is our first speaker. He's the Assistant Director. So Chris is an internationally experienced practitioner who has worked in disability services in both the UK and Australia since 1996. He is currently the Acting Director of the Positive Behaviour Support and Restrictive Practices team, a statewide team specialising in positive behaviour support plans, which include containment and/or seclusion. Chris has degrees in social work and social science with social policy and criminology, and holds a postgraduate certificate in specialist practice in relations to mental capacity and best interest decision making. Whilst in the UK, he was responsible for implementing the local autism strategy as required and under the Autism Act 2009, and devising, developing and leading the resultant autism service for the local authority where he worked. This included sector-wide training, including presenting at the National Probation Service Annual Conference in relation to working with offenders with an autism diagnosis. Chris is an experienced presenter who is looking forward to the opportunity to present to the team at the NDIS Vet Principals and Vet Practitioners Leadership Program.
So yes, I'm Chris Booker, and as Sam said, I'm the Acting Director for the Positive Behaviour Support and Restrictive Practices team with Queensland Government. So one of our main roles is the authorisation of restrictive practices for adults with a cognitive or intellectual disability in Queensland. So just to set the scene, and just to also make the point that as well that so Morag and I, obviously from different organisations, with Morag being from the NDIS Quality and Safeguards Commission, but we do work within a co-regulatory system. So what we tend to do when we do these presentations is chip in with each other. Also noting that the role I'm in at the moment used to belong to Morag, so we know each other really well. Okay, so first, in terms of setting the scene, what is positive behaviour support? So positive behaviour support is a very particular way of supporting people. Now, we work, as I said, with people with adults with a cognitive or intellectual impairment, but PBS is something that's been developed originally it was developed for children with autism in a school setting, but it's a really, really useful tool and is applicable to many ways, and in fact probably under different names is used in many different arenas, including management. So basically, positive behaviour support is a multi-component framework, and by multi-component we mean there are different elements to it that build up to positive behaviour support. So it's developing an understanding of the challenge in behaviour, or as we refer to it in Queensland, behaviours of harm, displayed by an individual based on an assessment of the social and physical environment and broader context within which it occurs. We also involve other people, so it's a very environmental and holistic way of looking at a behaviour. So it's not just about what is the person doing, it's what is the person doing in the context of where they are doing it and who they are doing it with, because people behave in different ways with different people, and it's completely usual to hear from one service who says we're having all these difficulties, and then another service working with exactly the same person who says, well, we're not. So it's really important in terms of the context of getting support right to work out why someone might be behaving in one way with one group of people, but completely differently with another. So we then use that understanding to what we call undertake a functional assessment. So work out what's the function, why is the person doing what they're doing, and when we get that, we can implement a positive behaviour support plan. And the whole idea of the positive behaviour support plan is it enhances the quality of life for the person, and it reduces or eliminates the need for restrictive practices, which is where Morag and I spend most of our days. So what's the difference between positive behaviour support and restrictive practices? Well, the first thing that it's really, really important to note is that you can have a positive behaviour support plan that does not include restrictive practices, but you cannot use restrictive practices without a positive behaviour support plan. So positive behaviour support is all about being proactive, is looking at those proactive and reactive strategies to behaviours of harm. And a really important element of that is skills development. So using that positive behaviour support in order to teach the person you're working with new skills so that ultimately they can manage the environment, or they can manage the trigger point independently. That's what we want to get to. And it also teaches that person to manage that without using challenging or behaviours of harm. The good thing about positive behaviour support is, because it's so tailored to the particular individual, is that it can lead to long-term behaviour change, because it's all around choice and empowerment and improving quality of life. And it respects the human rights of that person. Whereas restrictive practices is incredibly reactive, and it really is just your last resort, because it doesn't teach the person anything other than, if I do this, someone is going to do this to me. So it has higher risk because we are getting into the realms, for example, of physical restraint, if we're using a physical restraint, or deprivation of liberty if we are using containment and or seclusion. Or we're just not allowing somebody to have access to their own things if we're talking about restricting access. And also, we can't forget that this is, when we're talking about restrictive practices, we're talking about doing something to someone or on someone. So there isn't that collaborative part to it. It is very much someone does too. So that also has that emotional impact on the person who is doing the restrictive practice. So it can make it sound, and it can release the emotion of the punisher. That'll teach you a lesson. And the reality is, actually, it hasn't taught any lessons at all. Okay, so in terms of restrictive practices, because of that, what we saw on that slide before, where restrictive practices, there is very little positive about them other than that immediate response to a behaviour of harm. There are very, very clear guidelines and legislation around the use of restrictive practices. So as I reiterate, in Queensland, the authorisation of restrictive practices only applies to an adult. So in Queensland legislation, that is a person over the age of 18. And in accordance with Part 6 of the Disability Services Act, it is for an adult who has a cognitive or intellectual disability. Okay, and on top of that, whose behaviour causes harm to themselves or others. So the legislative framework is one of the most complex in Australia, and part of that is because it is old in comparison to other states and territories. So the Disability Services Act came in 2006, was passed and implemented, I believe it was 2008. That was before I was here. And that was in response to the Carter Report. The Carter Report is well worth looking out for, and it's still online. You can still read it. It's been through a couple, the DSA has been through a couple of iterations. It was reviewed in 2014 and reviewed again in 2017, I think, when the disability services regulations were passed, and is due to be reviewed again soon. So the DSA works in tandem for adults with cognitive or intellectual disabilities with the Guardianship and Administration Act 2000 and the Public Guardian Act 2014. So for all types of restrictive practices, there has to be a very clear requirement in terms of the use. So it has to be necessary to prevent the adult's behaviour causing harm to the adult or others, and the least restrictive way of ensuring the safety of the adult or others, and compliant with the positive behaviour support plan for the adult. So until 30th of June 2019, the state was responsible for both the authorisation of restrictive practices and reported use of restrictive practices. From 1st of July 2019, the NDIS Quality and Safeguards Commission started in Queensland, and they now have responsibility for reported usage and regulating the usage of restrictive practices. However, each jurisdiction, each state and territory has retained the responsibility for the authorisations. So in Queensland, we are under what we refer to as a co-regulatory system. So the Positive Behaviour Support and Restrictive Practices team, the team that I work with, we continue the statutory function and responsibilities as per the DSA, and we work with providers to ensure they understand the division of responsibility between the state and the Commission. And sometimes things don't completely neatly line up, including the definitions of what a restrictive practice is. But both Morag and I are clear in our understanding and how we can make that work for an individual on the principle of what we don't want to be happening and what we both have in our respective legislations is a principle of one person, one plan. So, as I said, we are governed by Part 6 of the Disability Services Act in the PBS and RP team. And we've retained the following responsibilities as state government responsibilities. So we are responsible currently for developing positive behaviour support plans, which PBSP, for all Queenslanders subject to containment and seclusion. So that's approximately 34 plans in the non-government organisation sector. If you include the AS&RS containment seclusion plans, then it's around 54. We are also currently responsible for developing all PBSPs for clients of the Department's Accommodation Support and Respite Services, AS&RS. So inclusive of the containment seclusion plans, that's approximately 125 plans. Those figures haven't changed markedly since those numbers. Additionally, and this is a third stream to what the PBS RP team is responsible for, is providing approvals for the short-term use of restrictive practices, excluding containment and seclusion. I'm going to talk about that more in detail in a moment. And that's by any disability service provider in Queensland. This has been updated massively. So 176 approvals in 2018 and 19. Since 2019, where it's become more of a focus of ours and more of a focus of the Commission's attention, as you can see, there were 307 in 2019 to 2020, and that was 484 received. And so far in 2020 to 2021, we have had just shy of 500. So we're seeing an increase over the period from 2018 to now. And so far this year, obviously we're not at the end of our financial year yet, so we're expecting it to break 600 again. The classifications of restrictive practices in Queensland legislation. This is really important to note because this will be different to what Morag talks about when she's up next. And feel free to chip in, Morag, as we go along, because I've said you probably would. Okay, so in Queensland, we have 6 classifications of restrictive practices. We have seclusion, which is confining an adult to an area from which they have by themselves, from which they have no free exit. Containment, which is contained within the home or grounds where a disability service is taking place. mechanical restraint, which is the use of an object or an item in response to a behaviour of harm. And there are some exceptions to that in Queensland legislation, including the use of belt buckles, belt buckle covers and harnesses, which Queensland refer to in a vehicle as for safe transportation. Again, that's different to the Commission, and that's a focus of ongoing communication between the Department and the Commonwealth. There is also physical restraint, which is using any part of your body to prevent the free movement of another person. You don't necessarily have to make physical contact with the person to be using a physical restraint. If you are standing and blocking and not allowing that person free movement to do what they are intending to do, if that is to cause harm to themselves or others, then that is classified as physical restraint. Then there's chemical restraint, which is quite clearly the use of a medication in response to the primary purpose of a behaviour of harm. And there are two classifications of that. There is fixed dose, which is following a medical professional's prescription, or there is PRN, or as required, which is the use of a medication in response to a behaviour of harm when that adult is engaging in behaviours that will harm themselves or others. And then there's restricted access to objects is how we often refer to it. It's referred to as restricting access in the Act. And that is, again, restricting that adult's access to a particular object which is used to harm themselves or others, or there is a serious risk of harm to themselves or others. Most frequently, we will see that will be knives and other sharps kept in the kitchen. So Queensland currently works in accordance with a guardianship model. So where a restrictive practice is first identified, a service provider will make a short-term approval application to Queensland Government. Where it's not containment or seclusion, so where it's for one of the other four restrictive practices of physical restraint, mechanical restraint, chemical restraint, and restricting access, the principal clinicians within my team are the delegates of the Chief Executive under Section 178 of the Disability Services Act to consider and, if they deem appropriate, grant a short-term approval for the use of a restrictive practice for up to 6 months. Where there is a need for a person to be subjected to containment and or seclusion, as well as other restrictive practices, then the public guardian is the decision maker for the short-term approval. Now, the purpose of that is to avoid the conflict of interest, because where someone is subject to containment and or seclusion, as I said earlier in the presentation, the department currently has a statutory function to prepare those PBSPs. So it avoids the conflict of interest of the PO6, who is a delegate for those PBSPs, giving approval and then writing the plan. It gives that element of separation. So the purpose of the short-term approval, there is a lower threshold for approval because we accept that there is an immediacy of risk of harm, but a service provider may not have all of the data that they ordinarily would have and that we would expect to see for a full positive behaviour support plan. So the purpose of the short-term approval, the STA, is to allow service providers to seek the appointment of a guardian for restrictive practices who ultimately will sign off or consent to the use of the restrictive practices, but simultaneously to undertake all the necessary assessments and to develop a positive behaviour support plan, which can take quite some time. So as I say, a short-term approval can be given by either the department or the public guardian for a maximum period of 6 months. So once we have had the short-term approval, we will then move into what we refer to as the full approval. So there are a few different ways of having a full approval. So where containment or seclusion is in effect, then ultimately the decision maker, whilst the department approve the use of the restrictive practice or will prepare the plan with the restrictive practice in, QCAT, the Queensland Civil and Administrative Tribunal, will approve the use of restrictive practices in accordance with the Positive Behaviour Support Plan. And then the PBSPs for other types of restrictive practice are approved by either guardians for restrictive practice, which may include the public guardian as a guardian of last resort, or it would be a family member, or for certain restrictive practices, such as where there is restricting access only, an informal decision maker, which is referred to in the Act as a relevant decision maker. So there are different ways of gaining consent depending on what the restrictive practice is. The requirement for QCAT approval for the use of containment and seclusion is something that's unique to Queensland and is legislated both in the Part 6 of the DSA and also in the Guardianship and Administration Act. So as well as that, we also have the responsibility for compliance in relation to the authorisation of restrictive practices. So Section 195 of the Disability Services Act, so again still within Part 6 of the Act, places a legislative requirement on the relevant service provider. So that's the provider that's been given the approval either by QCAT or by the delegate of the chief executive or by a guardian or by an informal decision maker for the PBSP. If it's an STA, they have 14 days to notify the chief executive that a short-term approval has been given either by the department or by the public guardian. Or for a full approval, they have 21 days to notify the chief executive. And that's under a system that we use called ODC, or the Online Data Collection Tool, which is an online resource. Okay, so the department, in terms of our monitoring compliance, we track all short-term approvals issued by the chief executive, all AS&RS positive behaviour support plans, and all containment and or seclusion positive behaviour support plans. In addition to that, we will, where we are able to, we monitor compliance with all restrictive practices approvals, as service providers are required to notify the department that approval has been given. And that's one of the things that we do in partnership with the Commission as part of the CoRegulatory System. So by doing this compliance monitoring, it enables the department to identify service providers where a restrictive practice approval is required to be entered. And we have a compliance framework which sets out how non-compliance with reporting requirements will be addressed on an escalating scale from, and that ultimately that can be from ideally some advice and support at the lowest level up to a referral to Queensland Police at the highest level, noting that without a valid approval, if you lay hands on somebody, it's not physical restraint, it's assault. So there is that sliding scale of our involvement and where a referral for non-compliance will go to. Okay, so what you'll see here is some data about the different types of approvals that are given, noting as well that many people will be subject to more than one restrictive practice per PBSP. And you will see that restricting access is by far the highest one, just above chemical restraint. Physical restraint then is higher than one would have expected, with seclusion and containment being the least widely used, and mechanical restraint not entirely higher than seclusion and containment, but there is also some complexity there in terms of what is defined as mechanical restraint under state-based legislation in comparison to what is defined as mechanical restraint with using the Commission's interpretation. And I was saying earlier, Morag, that you and I spend a lot of time talking about that, including this morning.
Indeed.
Next one, please. Okay, so again, in terms of interpretations, now these pictures are, this is a real life example, and this was under your time, wasn't it, Morag?
Yep.
So this was a blue cage in a Canberra school, except it was not necessarily referred to as a cage. As you can see in the bottom picture there, it was referred to as a sanctuary. It was made of blue metal pool fencing, and it had a roof and a latched rear door. And this was raised with the Children and Young People's Commissioner. And it lasted for 14 days at the school before it was ordered to be dismantled. Did you want to say anything about this one, Morag?
I mean, this was in the media quite a bit at the time, and you've got to appreciate that this was a special school. There was a committee of people that decided that this was an appropriate thing to invest in, and then it was constructed and put in place, and they were trying to normalise it. The picture on the bottom with the sanctuary were actually pasted around the classroom to normalise it with the other children. So, but, you know, there's no way of normalising the fact that was a cage, basically. And there are Queensland examples where children and young people have been put into, you know, art rooms or storage rooms or various other things, you know. So what we call euphemistic language. Just because you call something a sanctuary doesn't actually change what it is, but it's, you know, seclusion, and so calling it something else doesn't help really.
Yeah, absolutely. Whenever I see this, I always think back to the UK's version of restrictive practices, which is deprivation of liberty safeguards. And I think back to the UK's version of RP, deprivation of liberty safeguards, and there was a review of some of the things that took place under a deprivation of liberty, and that was done by Baroness Hale. And whenever I think of this, this is an absolute literal example of, you can dress it up however you like, but what Baroness Hale said was a gilded cage is still a cage, and that's exactly what this is. And again, one of the things that worries me about the high number of physical restraint is that when you lay hands on somebody, there is a risk for both the person who is being restrained and the restrainer. So it's really, really important that where physical restraint is being used, that it's used within a tried and tested framework. Because when it goes wrong, the results can be catastrophic. And this is an example from, I believe, it was Milton Keynes, which wasn't too far away from where I used to live in the UK. And this was used in a youth justice environment. And yeah, there were several examples of particularly awful situations where young people were restrained, and ultimately the restraint used led to their death. So in Queensland, both in state and in commission, federal, there are what we refer to as prohibited restrictive practices, and so we will not approve the use of supine or prone restraint. So where somebody is held down, either face down or face up, they're prohibited. They will absolutely not be allowed.
There's also, in various states and territories, different prohibited practices. Some states and territories prohibit the use of seclusion for children and young people. You've got to realise that secluding anyone has psychological impact, which is sometimes most often not proportionate to the presenting behaviour that got the person secluded over a longer period of time. So it's a problem. We've got examples of where this technique, physical restraint techniques in Queensland have had the adverse outcome that Chris was talking about, resulting in the death of a person. And even in the public arena, there's been there was a young person restrained at a swimming pool by members of the public, and that person passed away. And people would recall possibly there was a fellow, not in the disability sector, there was an alleged shoplifter at a Bunnings store that was held in a prone restraint and also passed away. They were restrained, alleged to have shoplifted and so on. So the physical restraint carries a very high risk factor. People will sometimes, they're being restrained and they struggle, and the person that's restraining them thinks that they're struggling against the restraint when actually it's positional asphyxia, and people are struggling because they can't breathe because their chest or their airways are compressed. So it's very high risk. Yeah. And
there are also a number of physical restraints that are used which again are prohibited, which involve the use of pain management. Absolutely. Yeah. So it's one that we all take incredibly seriously. Okay. So in terms of when we're recommending use of restrictive practices, or where a provider is requesting the use of restrictive practices, we have to satisfy a number of criteria to meet the Queensland state's needs. So are we safeguarding rights? So in order, is what we are doing the right thing to do? And in order to determine if we're safeguarding rights and the human rights of the person, noting, is it the least restrictive way to manage the behaviour of harm? That's really important, because least restrictive doesn't mean do nothing. It means the least restrictive way to ensure that person or others are kept safe. Does the practice adhere to relevant legislation, conventions, policies and procedures? So we're really looking at, is what the provider intending to do based on the best evidence and best practice? And there's a lot of consultation that can be required about that. So, for example, as I say, if we are using a physical restraint, then we would be expecting those to be some very thought out responses to why and when that is required, and for the techniques to be within a framework which is based on evidence-based practice. Stuff that people know works. And similarly with mechanical restraint, it's not just something that you've tried, that you have had that clinical expertise in there from, for example, an occupational therapist, that this particular type of lap belt, for example, on a wheelchair, is the correct type of lap belt for that particular wheelchair and that particular person. And have the pros and cons been considered? So this is where, again, we're coming back to the least restrictive. So if we use this restrictive practice, is it proportionate to the harm that will be caused? Or even, is the use of this restrictive practice actually going to increase the risk to the adult? So ultimately, at the end of this, if we're satisfied that the restrictive practice is the right way to go, then there needs to be clear procedures written into a positive behaviour support plan, which have the proactive and reactive strategies up front and the restrictive practices as the last resort, with clear procedures of their use, and most importantly, a strategy to reduce and ultimately eliminate the use of those restrictive practices in the long term. Okay, so I won't spend too much time on this. This is just really for your information about how we get to that function of behaviour. So when we go in to this as a clinician, one of the things that where we will start is the challenge in behaviour, because that's what the referral will be. This person is doing this thing and it's not very good. So we then move to the consequence analysis. So the first part of the functional assessment is what happened. And by consequence, we don't mean go to your room. By consequence, we mean what does the person get out of this? What's the consequence for them when they do X? Y happens. So when we can work out with that, so this person starts hitting staff is the behaviour of harm. The consequence of that is staff leave the room. So from that, we can then start to go right the way back to what is the immediate trigger. So that could perhaps be staff are being too noisy, or staff are placing demands on the adult to do a particular thing that they don't want to do. So once we've got that, we can then look at the setting events, going back that one more step. And then we can put all that together ultimately to come up with the function of behaviour. Now, what the positive behaviour support plan does with the teaching strategy as an initial is there is a replacement behaviour. So teaching the adult to, rather than engaging in the behaviour of harm or the challenging behaviour, to use that replacement behaviour. So I'm feeling stressed at the moment. Can I have 5 minutes, please? Rather than walloping, which has the same functional outcome. And we use that as a first step to eventually getting the desired behaviour and a consequence. The desired behaviour perhaps being that this person uses other strategies, maybe wearing headphones, etc., to cope with a noisy environment at a particular time. That's a very simple example. It's often not quite as easy as that, unfortunately, but that gives the purpose of a PBSP. So in order to have that desired behaviour replace the challenging behaviour. Okay, so there are a number of resources on our website, and you can also speak to us directly either on the 1-800 number or using our inquiries email, which is here. No, I think I will have to send. I've been updating our website, so I will send Bev some updated links to our webpage.
Thanks, Chris. That's wonderful.
Thank you.